Good afternoon. On behalf of Rice University's Baker Institute for Public Policy, I want to thank you for joining us for this interesting discussion on enhancing the value of healthcare investments in the 89th Texas Legislature. We're really fortunate today by having some important decision makers from key aspects of our health care system here in the state. We're excited for their discussion moderated by our own Elena Marks, who's a senior fellow here at the Baker Institute. This conversation kind of was born out of a report that Elena and I published in September, and it's available through this QR code and online. And the concept of this report is just how we can increase the value that we're getting out of the healthcare dollars that we're already committing within Texas. And our kind of concept here is that we could increase the value of that by considering the factors that where people live and the conditions that they live in that kind of have an influence on their health outcomes. And this report is kind of meant to be a reference and a resource, and it's kind of a comprehensive listing of all the different options the state has for using funds to support services that meet the non-medical needs of patients. If you turn on the news and you're seeing information, stories about healthcare, invariably what you're going to see is a discussion about the price. You know, whether you have insurance or are uninsured, everybody's really impacted by the high cost of healthcare. And that issue of cost has really proven to be very intractable. It's been something we've been working on for a while, but you can see in this figure that it just keeps going up. In 2022, it's $4.5 trillion. By 2032, we expect it to be almost $8 trillion. And the U.S. is really an outlier if we compare ourselves to other high-income nations, places like Germany or Spain or the UK, who spend less than 10% of their GDP on healthcare, whereas we're approaching almost 20 now. Now, we probably wouldn't be so hung up on price if we were getting a great value for it. If we had the best health in the world, we probably wouldn't be complaining so much about price, but that's really not the case. This is a figure that shows life expectancy of the United States versus other high-income countries, and you can see up until the 1990s, we're kind of in the pack there, but we started to diverge and be underperforming. In fact, after the COVID crisis and the opioid crisis, we actually had a decline in life expectancy, where our other peer nations continue to go up and up. But it's not just how long we live. When we are alive, we're actually a lot less healthy than these peer nations. We're struggling with comorbidities of multiple chronic conditions. So this issue of the value of our healthcare spend is not just about price, but what's the quality of the health outcomes that we're getting for that price. And that quality issue is really what we're here to talk about today. We think that the quality of health of Texans can be improved if we consider not only meeting their medical needs, but some of the other conditions that they live in that affect health outcomes in significant ways. The county health rankings has a way to kind of think about this issue of what drives health. And according to them, you know, medical care definitely is an important factor in that. Access to care and the quality of that care accounts for about, in their estimation, about 20% of the overall health of individuals in the population. But other factors are even more important, like social and economic factors. You know, do you have access to education that can allow you to get employment and income and meet your other needs and obligations? One idea is to think about how we can use dollars that are already tied up into the healthcare delivery system to not only deliver high quality care with great access to all of our citizens, but also how we can address some of these other needs that might even have a bigger impact on health than just medical care alone. Now, where's this money coming from? Well, we're not really talking about new dollars here, and what we're looking at is the investments that the state is already obligating. Can some of those be used in ways that give us greater value by addressing non-medical needs of patients? The state spends a lot on healthcare, about almost $47 billion a year. The biggest portion of that was in health and human services, Of course, the Medicaid program is a large chunk of that, $41 billion, but the Children's Health Insurance Program is $500 million. We have a significant investment in mental health and substance use services. And then the Women's Health and Thriving Texas Families, which is about postpartum and pregnant women's care, has $150 million in it. And then the employees' retirement system and teachers' retirement system, by their name alone, you think they're about in the retirement years, but they actually are also the systems that negotiate the health insurance policies for the teachers and the employees. There's about 340,000 direct teachers and employees in that program, and then with their dependents, that program even grows. So there's opportunities for the state to direct and determine what's covered in those plans, and consideration for non-medical needs is one way they could improve the health of those teachers and employees and maybe save money. So when you think about how the state might choose to use funds in ways that benefit patients by addressing their non-medical needs, it's not, it's not a niche area that just has one kind of loophole to use. There's actually like very traditional mechanisms within the state for addressing this, and there's quite a few of them. So this is not a niche area. It's actually very broad, and what we talk about in our report is other states are using all of these different mechanisms to do things like help with housing for people who are unstably housed or people who have need nutritional supports. We kind of think about this in two different areas. One's within the Medicaid bucket. They have things like 1115 waivers. A big topic right now for the legislature is in lieu of services, which is a program that allows you to kind of substitute, some of these non-medical services if they're going to improve the health and prevent the need for further health care services at a later date. And then on the right-hand side, there's these other state resources like TRS and ERS and the Women's Health Program. So this is just a background for how we're thinking about this issue of identifying and addressing non-medical needs of patients to improve health and reduce costs. But what we're really here for today is to hear what decision makers think about how to do this. So I'm going to bring our panel up to the seats right here, and I'm going to turn it over to our moderator, Elena Marks.
Whoops, I just dropped her. Thank you. All right, wherever y'all want.
Where do you want?
Okay.
Okay.
All right.
Or we could all just shift, make it more fun.
Yeah, I have my notes, and so I know who I'm calling on at least first and second, so you can sit wherever you want.
All right.
So first, thank you to our panelists. Their bios are at this QR code, and they're too long to take up so much of our time here today going through them. You have their titles up here behind you, but you've got people who are absolute leaders in their field. And the policy report that Charles was just talking about is a big, funky, wonky sort of thing, and probably none of you is going to read it. And that's okay, because there are people probably who work in your office who are reading it, and others who are actually able to make these changes at the agency or legislative level. So what I want to do on this panel is talk to each of you in very practical terms. You don't have to know which mechanism would make a difference for you, although I think Dr. Huber probably does know that. But I want the audience to hear from you about the work you do, the populations you serve, and how allowing more flexibilities for you to use the dollars that are already committed to the system to do some of these non-medical services, to meet some non-medical but very important health impacting needs would affect your patients. So I'm going in a particular order because I want you to hear first from the people who are in the field doing the work, and then from people who have a connection to the legislative process and can talk about, so how do we make the kinds of policy changes we need if we want to see this work advance? So I'm going to start all the way over on the other end with Wayne Young. You serve a really complex population in Harris County. People who have mental, behavioral, and physical conditions that are really serious. Many are homeless. They are people who are really in dire circumstances and some of the hardest to treat. So talk for a little bit. So give us a brief description of the Harris Center that you run, and the kinds of patients you serve, but what I really want the audience to hear about is the work you're doing that is not in the medical space that is impacting your patients and how that makes a difference.
Absolutely. So I appreciate the opportunity to be here this afternoon. My name's Wayne Young, and I'm the CEO of the Harris Center for Mental Health and IDD. If you're not familiar with that, which wouldn't surprise me because it's not a robustly known part of our system, we are what's often referred to as the local mental health authority and local IDD authority, or intellectual and developmental disability authority. We are essentially the public safety net mental health system for Harris County. There are 39 centers like me in Texas. We cover all 254 counties. Fortunately for me, my focus is Harris County. We have about 2,650 team members who last year provided services to just over 96,000 Harris County residents. All of them with very significant mental health concerns, substance use disorders, and or intellectual and developmental disabilities. And so it is a very complex population. Half of our population are below 100% of the federal poverty level. The other half are below 200% of the federal poverty level. So I've got maybe 1 or 2% that's a little above that. Mostly children that are experiencing developmental delays that they know are going to be probably long-term delays, and so they're engaging in our system early in their lifespan. And so it is a complex population with very significant needs, with very complex case situations often, right? Very limited resources. But what that leads us to is some of the non-medical things that do, and when I say non-medical, behavioral health services in my mind are medical services, right? They're a part of the healthcare system. But the complexity and the lack of resources that the people we serve find themselves in require us to think about other components. Elena mentioned many of them are experiencing homelessness or are unhoused. And that's probably some of the work that got us here. We have lots of projects. We have partnership with the food bank where they bring food on site and distribute at our locations. But the one that's garnered a lot of attention lately is the realization that our team and our board has that people without a stable place to live are going to really struggle finding any kind of recovery from mental health. And so what do we do to lean into that? And for the vast majority of those we serve, housing, traditional housing, scattered housing, landlords, traditional community settings is the absolute right answer. But what we know is that some of those, especially early in recovery, have problematic behaviors or challenging circumstances that don't make them very likely to be stably housed in traditional community settings. And so what we believe is that some of them, very small number, need the kind of housing that is very closely aligned with their behavioral health provider. And so we are literally in the midst right now of building 26 apartments, part of that in partnership and with help from Community Health Choice, part of it with funding from the state. The state, about 10 years ago, 2013, created the Healthy Community Collaborative, which is a pool of funds that are distributed, focused on individuals' mental health at the intersection of homelessness. And so they are funding about half of the construction of those apartments. The city is funding part. Community Health Choice is funding the other, recognizing that this population that's unstably housed or unhoused completely, if we want to help them find recovery in mental health, we're going to have to be able to lean in on some sort of stable housing. My goal is for them to be with us for a year or two and then help them move into regular traditional community settings. But in order for them to be successful, at least this really small group, we're going to have to lean into that stable supportive housing. And so, and there, to your point, the mechanism, the legislative funding allocated, it doesn't go through Medicaid. It's not something that Medicaid would typically be able to do. Their investment in capital is to prioritize access to members to those services. But there are ways that we can lean in on some of those issues and help direct those funds.
Thank you. Let's go to Dr. Callender. You run the largest healthcare system in our region. You see people at their best and their worst times. and everybody in the room knows Memorial Hermann. I'd like to hear a little bit about just top lines on Memorial Hermann, but what I really want to ask you about is you are screening your patients now for all of these non-medical needs. Are they food insecure, housing issues, all sorts of non-medical needs, and you're increasingly required to do that by regulatory bodies. What are the how do you think about, so you know all this about your patients, you know how health impacting these non-medical services can be, how do you think about getting those needs met, and what are the opportunities to do more in that area from a policy and financing perspective?
Yeah, and we could talk for days about that among us. What's the best way to approach this? Memorial Hermann's very proud of its history here. We're the only private, nonprofit, community-owned health system in this region. We were founded in 1907 in downtown Houston as the second hospital system here in Houston. And at that time, at its founding, what became the Memorial System was dedicated to improving health for the needy. Because at that time, there wasn't really much recourse for people who became sick who weren't well-to-do. Then George Hermann did the same sort of thing in 1925, leaving the bulk of his estate to form the Hermann Hospital. The two organizations came together in the mid-1990s. But we've never really wanted to move beyond that legacy of service to the needy. We've been doing things for a long time in the community. We started our current efforts a little over 25 years ago by investing in clinics in public schools. We now have 10. They serve about 85 schools around the greater Houston region, and they're located in schools and school districts where the districts serve an overwhelming majority of needy students. And so through that, not only have we been able to care for the students, but we've been able to extend care and also opportunities to offer health knowledge, additional health literacy to families. We formed a separate corporation to focus on how we could, either on our own or through partners, make investments in the community. So we've been investing to try to focus on food insecurity, the creation or acquisition of more safe and secure housing, opportunities to enhance not only health literacy, but other forms of primary and secondary education for quite a number of years. We know the data very well, and by the way, I did read the report, and it is outstanding. It describes succinctly the problem that we have in this country, which are the health outcomes that we generate from spending trillions of dollars, are the worst among the industrialized countries in the world. And those outcomes are actually getting worse as opposed to better. Those of us who have been delivering health care for a number of years haven't moved those outcomes. In fact, they're getting worse in spite of all we've been doing in our hospitals and clinics. So what we're trying to do as a large health system here in Houston is show that if we're going to move the needle relative to accomplishing our mission of improving health, we've got to get outside our hospitals and clinics. Now, we are not going to give up on providing the very highest, best health care that can be achieved, but we want to do that for everyone. And we understand the approach is not about the specific health care, but it's about personalizing what we know about health care to meet the needs of each individual patient. And that includes taking into account the non-medical drivers of health. We know that we can't solve all of the problems on our own, but there are many that we can address and identify solutions and then bring other partners along to create a broader effort to create more impact. In other cases, we need partners, like with food insecurity, to be able to address the issues that are out there. But we think a very important part of what we're doing, Elena, you described, is doing the screening. Really understanding for each of our patients that we encounter in our system, and in many cases they're direct family members or people who are in the same household, what's the status? What's their status relative to these non-medical drivers of health? And then think about what we currently can offer, what we can pilot, what we can think about in terms of additional innovation that's needed, so we truly can move the needle over the course of time. I wish I could say that we're well on our way to solving all the problems. They're so big. We need a lot of help from our colleagues here, the policymakers, the legislators, and our colleagues in healthcare and in the United Way, the American Heart Association, the Houston Food Bank. But I think if we all work together, we truly can raise the level of health and well-being in all of Houston. And I think all of us in this room understand how important that is for the future of Houston. We need a healthy workforce. We need to be able to attract employers to come here because of that healthy workforce. And so it definitely is important to think about how we do that, what investments we can make today, what concepts that we can try that perhaps haven't been tried or tried on a scale in which they can make impact, show which ones work, which ones are a little harder to make work, and then use the resources that we have available to optimal advantage to move that needle.
Thanks. All right, going to Lisa Wright. I want you to tell the audience about Community Health Choice, and then without getting too in the weeds, I want you to talk about what you do to meet non-medical needs of your members, particularly your Medicaid members. And then if you'll wrap all that so that we can flip over to Dr. Huber with what are the constraints and opportunities from a policy perspective that could help you do more of the kind of work you're doing.
Absolutely. So thanks so much. My name is Lisa Wright, and I'm the President and CEO at Community Health Choice. We are a managed care organization, also known as a health insurance company. We are based right here in Houston. We serve about 450,000 individuals, and we work with underserved communities. We are here for the safety net, and so we are partnered with HHSC and CMS and deliver for Medicaid, CHIP, and dual special needs types of products. And our organization was really built on social determinants of health. We have always partnered with the community advocates, with community-based organizations to really look at the whole person. And so for us, it's not just really about their physical health and their behavioral health, but it's also about their social health. And what's interesting about our company, we have teachers and we have executive coaches that work with our membership, because when we think about social determinants of health, we're really looking at not just transportation, not just sort of economic empowerment or housing or food insecurities, but we're really looking how we can help build a person up and really return them out back into the workforce so they can be economically empowered, so then they can take care of themselves. And so one of the things that we do, we have a program that's called Career Ready. And so we do lots of research to find out what are the top associate degrees. And then we work with our Medicaid population, with the moms or their boyfriends or their husbands, and we help send them to a community college. And we help train them, and our biggest job is to remove all of their barriers. So we're gonna make sure they get transportation, we're gonna make sure they get babysitting, we're gonna make sure that somebody is there to make certain there's dinner ready. We're gonna do everything to honestly remove all the excuses from stopping them to graduate. And then we have recruiters on our staff that work with a lot of employers here in the Houston market, and we help to find them entry-level positions. But before they graduate, we let them understand that if you major in this, you're gonna get paid this, and we help to create a pathway so they understand that next step to getting a 4-year degree and then what their future could be. And so we do that even as a health insurance company, because we recognize that if they're trying to deal with not having transportation, not understanding where their next paycheck is coming from, they're never going to get their physical or behavioral health needs taken care of. And so we've been doing that for a number of years. And when you ask about policy, there have been, I feel like at least this last 4 years, so many policies. If we think about what's been added in lieu of services, the 1115 waiver, there have been so many policies to address things like transportation, non-emergency medical transportation, and even how we look at social determinants of health from the practitioner standpoint and being able to determine where and what the need is. But the barriers that exist are honestly the payment mechanisms. And the biggest challenge that we have is how are we going to pay for it? And so we're a health insurance company, but what people don't realize is that for a community-based health insurance company, every dollar I get, 90% is going to behavioral or physical health. And so that only leaves me with 10 cents to really cover administration and cover things like social determinants of health. And so the question becomes, how do we pay for it? And CMS, I think, is putting some things out there where they're trying to add PMPM payments to allow states to really look at how to fund social determinants of health through the physician side and how to code, and so we can learn more and get more information and more intelligence about it. And so I feel like there are things that are being done, but our biggest barrier is probably not only how we pay for it, but honestly how the legislation is written in order for us to execute it. And I always think that this is a really just sort of simple example. We were solving for transportation. So you can go to the doctor, we solve for your transportation, but you couldn't go to the dentist. So now we added non-emergency medical transportation. Well, perfect. So now you can go to the doctor, you can go to the dentist, but the pharmacy's at HEB. You can't go to HEB. And so we're not able to get the member all the care that they need. And so that's a simple, I think, example of how policy is creating a barrier.
Okay, thank you. Moving up in the policy category then, let's go to Carol Huber. Carol is the chair of the Value-Based Payment and Quality Improvement Advisory Committee. That's a mouthful. It's a committee that the legislature has created. And so if you'll tell us what the committee's job is and talk about the work you've done and the recommendations that you've made to the legislature in the last few years about how to solve some of the problems that the other speakers have described. How can we use policy to better advance non-medical solutions when that's the tool you need?
Absolutely. Thank you for having me. I'm Carol Huber. I work for University Health in San Antonio. I lead our Institute for Public Health. We also have a hospital district-owned health plan, and so I've spent about half my career on the health plan side and half on the provider side. And so this committee, the Value-Based Payment Quality Improvement Advisory Committee, is a forum for people like really many of us on the panel to come together to identify innovative solutions to improve quality, to improve outcomes for Texans. And we primarily focus on Medicaid because it's such a big component, but we really look across other funded programs as well, like the Employees Retirement System or anything that would really have an opportunity to improve the health of Texans. The committee itself being called Value-Based Payment, a lot of people think that's all we focus on. But really that is a means to the end. It's how do we use that or these other levers, these other authorities to improve access to care, to improve those health outcomes, to make people healthier. Because we know that if they're healthier, it doesn't just end there. It goes back to what you've heard some of these other panelists talk about. They become more career ready. They contribute more to their communities. They really contribute to economic growth and help us catalyze the communities in which we live. So our committee was formed in 2016. We are getting ready to publish our 4th report. And you'll see a lot of common themes across those 4 reports, and non-medical drivers of health has been a consistent theme throughout. It's important for me to say that the opinions that you'll find in the recommendations that come out in December are those of the committee members themselves and not of HGC or the executive commissioner. But they were unanimously voted on by the individuals in the committee, and those individuals include people from hospitals, from industry groups, from health plans, from other stakeholders. So really listening to a broad voice of individuals and experts who have a lot of experience in this space. So I can share with you, we have 4 work groups that we split into to do this work. And one of them is specifically focused on non-medical drivers of health, and I'll share those recommendations here in a second. But I think it's important to recognize that the other work groups that we have all have another tie back into non-medical drivers of health. So it is such an important issue that our work group focused on data, our work group focused on alternative payment models, our work group focused on increasing access to care in rural Texas, all have identified some component of this that ties back to community health workers, whether it be how to pay for it or how to use community health workers and things like that. So in terms of the non-medical drivers of health specifically, we really focus on those federal authorities, those levers that Charles and others have spoken of. In our last report, we really highlighted in lieu of services as a key strategy. We still think that's a really good tool. But at the end of the day, we want to use any and all of them, whatever works best, whatever fits into our structure here in Texas. And the key is to bring those stakeholders together, because the providers can't do it by themselves. The health plans can't do it by themselves. The legislature can't just write policy or write legislation and make it happen. We need the housing experts. We need the behavioral health experts to come together and use their own expertise in a collaborative way to achieve that success. And so that is really one of our first recommendations, is to understand that these authorities exist and how can we leverage them to the good of all Texans, and particularly Medicaid. And the second one is, you've heard some great examples here about how individual providers or health plans have great programs, right? They are connected to the food bank. They are connected to housing. They are offering paths to education for their members and potentially paths to employment. And those are all great. But what is a larger sustainable solution, right? We can't just give people a food bag when they come to our clinic, because food is heavy and it is really hard to get that bag of food from the clinic on 3 buses back to their homes, right? And we connect them to the food bank. But are there ways that Medicaid, when they do enrollment files, can also share information on which of these members are enrolled in SNAP or WIC or are not enrolled in those things, so that we can maybe expedite getting them connected to the services for a much larger long-term strategy. And so that was our second recommendation. And then our third recommendation really has to do with House Bill 113, which was recently passed, that encourages the state to do a study. House Bill 113 gave health plans the ability to categorize their use of community health workers under their medical benefit rather than an administrative fee, which is great, right? But that still requires money. But we'd like to see how health plans are taking advantage of that, what are the outcomes of those initiatives, so that we can see if that's something that we want to then take to a next level. So that's the 3 of the 12 recommendations that I'd love to talk more about, but that gives you a flavor of the kinds of things that we talk about and come together to unanimously support.
Thank you. And that's the pathway to getting information to the legislature. So, Senator Alvarado, you have a long history of understanding the importance of non-medical factors. You've been working on environmental issues and other issues for decades. And you were one of the co-sponsors of House Bill 1575 last session, which specifically recognized in its language the importance of non-medical drivers, and that's the bill that requires that pregnant women on Medicaid get screened for non-medical needs, and that they get significant case management to actually get those needs met it doesn't pay for those needs, which is a little bit of a glitch. But it was a big step forward, and from where we sit at the Texas Consortium, it was a great thing because it acknowledged the reality that non-medical services can be more important for some people than medical services, and we ought to pay for them. We ought to use healthcare dollars to pay for them. And you just heard from Dr. Huber about her report, a lot of these recommendations they've made before. So how do we work with the legislature? Where do you see this going in the next session? Are there openings? What do you advise advocates from across the sector to do to get some of these things that are kind of technical in nature, and they're not like a big wow kind of thing, but really important to improving health outcomes?
Yeah, thanks for having me, Elena. It's good to share the stage with you, and thank you all for the work that you do in this arena. Everything that happens that's good in healthcare has been so very incrementally, very slow steps. Just expanding Medicaid, to 12 months from 60 days for postpartum. Those little steps, and this bill that you just mentioned, the fact that we're just recognizing these non-medical factors that play into people's health and health outcomes was a big step. A lot of times, unfortunately, in healthcare has become a partisan issue, and it has no place in that, and we're just seeing a lot more of that coming into play as the political landscape goes from one end to the other in the legislature. But I think you're coming with some hard evidence, data that you're putting together, that many of you are working in, and taking that to the members and talking about that. I think that's very convincing. And just, where I grew up in the East End dealing with chemical companies and refineries, I knew just as a kid that had impacts on people's health, the people that worked in the plants, people that lived in the neighborhood, fighting for health, people to come in and do health studies, go door to door, the grassroots type of way, and talk to people. And now, what I was saying as a college student, people now realize that those individuals have more asthma, more cases of cancer and cancer clusters that we hear about. So all these things kind of come full circle, and we're going to continue the battle. But these small steps that we're making are, we take it, and hopefully we go back next session and we can build on that. Many of us have been filing bills to expand Medicaid. We're one of just a handful of states that just have some passed expanded Medicaid, and really for no real factual reason. But just in 2023 alone, it was estimated that Texas left about $11.9 billion on the table. And that's a shame, because that money could be spent to treat people. And as it was mentioned in our budget, how that cost continues to go up, and we just have so many people. We're the state with the largest population of uninsured, and we like to say everything's bigger in Texas, but not that. We don't want to brag about that.
Right.
We want to brag about the solutions and the gains that we can make.
I have a follow-up question for you. And I want to see if audience members have questions. We have a hard stop at 6 o'clock. And so if audience members have questions, I'd rather have you go after I ask. I got to ask Carol one more thing. And so far, this integrating non-medical drivers has been bipartisan or nonpartisan, even at the federal level. Some of this work started under Obama, but Trump actually ramped it up, and Biden has too. And the 1575 that passed last session was sponsored by a Republican. So how do we keep this nonpartisan? And I am totally for Medicaid expansion.
Right.
I don't talk about Medicaid expansion in the same sentence. What do we need to do to make sure that this doesn't become a partisan, Democratic-oriented bill when it's really just about value in health care? How do we?
I think when we go back next session, we can look at the outcomes from the bill. I think it was 2 Republicans, I believe it was Senator Colcourse. Is that Colcourse and Hull? Was it
Colcourse and Hull? Yeah.
Colcourse and Hull?
And it's just now being implemented, so we don't really, we're not going to have
so
any data
we may not
from it
have
for a while.
all the data, but I think if you can expand on that, and that applaud people and say this was really good. We're going to have some excellent outcomes from this, and just what else can we do to talk about these non-medical factors that are having such a significant impact on people? If you follow me on social media, I'm always tackling Union Pacific and concrete batch plants. But I think you can keep in that same conversation, if you're not talking about Medicaid expansion, but you're talking about these drivers that are just contributing to some dire health outcomes that are weighing on our budget, if you can keep it to talking about the way it impacts the next budget coming up, we're going to have over a $21 billion surplus. So hopefully we can tap into some of that money. But I think just keeping to the facts, and if you can point to real live stories, people that are being impacted by legislation that's passed, and layering it up with all the good work that these folks are doing here on the panel.
Elaine, I think it's important too to help our policymakers, legislators understand this is not just a public health issue. This is a workforce issue. This is an economic issue for our state. We know our state is undergoing, we're not sure what the pace is going to be, but an economic transition. And we need a healthy workforce for the future. We're extraordinarily blessed to have a young workforce as we compare ourselves to other states and what they have, but we've got to make sure that it's healthy. And today it's not as healthy as it needs to be to secure that economic future. So, Senator, you've talked about that to some extent. Is that a viable
Absolutely.
pathway?
We talk about those things. We have to use certain terminology to get people's attention. But I am concerned about the workforce. We do a lot to make sure that we're training people, but we want them to be healthy. And we also need to be proactive. How do you get people to encourage them to join a gym, to get physically active, to have access to grocery stores, food deserts all over my district? That contributes to people not having access to proper nutrition, fruits and vegetables. Not everybody can, drive to Whole Foods or Central Market, but a lack of grocery stores. That is something that impacts low-income neighborhoods. And again, as I mentioned, that concrete batch plants, most of them are located in Hispanic and African American neighborhoods, and those have some serious health impacts. And we're just now, I'm making some very small changes in that, and allowing for the public to have more comment, more participation, and cracking down on some things that need to be addressed in the permitting process.
Thanks. All right, let's start up here. Jean.
Hi, my name is Gene Raphael. I'm at Texas Children's Hospital. So my question is, one issue that comes up with non-medical drivers is this question of return on investment in the wrong pockets problem. Such that Dr. Callender, how do we convince him to make certain investments with him understanding it may not benefit Memorial Hermann directly, but it may benefit community health choice. So that creates some disincentive for him to potentially participate. So how do we work cross-sector collaboratively to overcome the wrong pockets problem?
Yeah, one of the things that I see, the good news is we do have a lot of nonprofits that are really dedicated to their missions, and they're pretty well funded, again, relative to other states. and they're going to continue with their mission work. What incentives, though, can we offer to facilitate working together, to enhance or increase the collaboration, to get us out there and innovating more together? I think that's a really great question. I think some of the suggestions in the report that have come out of HHSC and the panel, are really great in terms of using, for example, the directed payment programs and kind of ramping up, if you will, the incentives for us to work together and offering some incentive for providers and managed care organizations in terms of opportunities to generate additional funding for their programs, but really to drive the collaboration, probably a little carrot and stick as we go forward to say you need to do these things, but when you do it and you do it well, then it creates this opportunity for you. So I'm not an expert in that area, but I think that could help a lot.
I agree. That's a very good observation and a challenge I think everyone has experienced, because right now everyone knows it's the right thing to do and they're trying to do the best they can do with what resources they have. So it's going to take a system-wide solution, something like using the in lieu of services lever that would increase capitation rates for the health plans so they have more money to pay the providers, whether it be the healthcare providers, the behavioral health providers, or that community partner to do that work, and then everybody wins at the end, most particularly the patient or the member of the client.
And I think there's also, I'm sorry, Lisa.
No, go ahead.
I think this isn't true for Lisa, but historically sometimes providers and the payers have not been aligned well and have even had conflict in that dynamic. But I think everyone is kind of growing in their understanding. One of the things that we've been pretty successful at is a shared savings model to where we can, the MCO can invest in some services, we can demonstrate the value of that services, and only then does it return if there's some savings there to be realized. And then when that happens, it can be shared across the systems and across providers in ways and systems in ways that might not have traditionally been there. It takes a lot of trust and it takes a lot of development. Those are complex, and it takes sometimes even a couple of years for you to be able to show that return. But I think there's some promise in that practice that's not predatory but is partnering in our systems.
I would just want to add that, it feels like we have to align our incentives. So we talked about value-based contracting, and there is an opportunity through value-based contracting for us to move from sort of this quality model to more outcome-based model. And so when we were talking earlier about sort of what's the value creation, and now we're thinking about what is the true outcome. Are we improving outcomes? And so I feel like there's this period in time that we really need to look at these shared savings models and just make sure the incentives are truly aligned.
Another question?
I'll read it. I'm a customer of Community Health Choice and a patient of Memorial Hermann, and I did read the first half of the report.
Thank you.
So there's the big target that I noticed, first page, that's within Medicaid, but also outside of it is nutrition, which leads to obesity, diabetes, and lethargy, and also and food insecurity, also because of the cost, because of what people eat. And I have, these are just layman, simple ideas, but I have two concrete little ideas more for the legislature than anything else. One is reinstate home economics in schools. I know Texas isn't big on public education politics, but home cooking might be a hit to the GDP because of restaurants and all that, but the health benefits, and that's what we're talking about here, will give people energy and enthusiasm and could offset that if you can put a number on that. And the second one is a small program that Texas could do to encourage restaurants to provide a labeled category of meals that are nutritionally sound, like USDA choice, something. It would have to be voluntary, but it would take some money to implement.
I tried doing that a long time ago when I was in the House, trying to get the labeling, the nutrition facts, but that just wasn't going to go anywhere. Restaurant Association poo-pooed that very quickly.
Yeah, and to Senator Alvarado's great credit, she introduced the bill in the last session. It made it out of the Senate, but not quite through the House before the session expired, but to fund school-based clinics more broadly across the state. And again, a number of us in healthcare have demonstrated the impact of those, improving academic outcomes, graduation rates, and health, not only for the students but families. It's another way to get health literacy into households, so I'll add that to your list of requests, that you bring that back.
Well,
See if we
thank you,
can
because
get it
we
very-
worked with y'all. We worked
Yeah.
with Freddie Warner and others on that, and I was shocked that we got it out of the Senate.
Well, we hope you'll try
Yeah,
again.
yeah, we will.
Okay.
We will.
Question here.
Yeah, having worked for the Harris Center in the recent past, and it was a good experience, and 29 years.
I was waiting on the next word.
You're waiting for the butt.
Oh, boy.
Also working 29 years for UT Houston as a psychiatrist. One of the things that the Harris Center has managed to do over the last few years that's wonderful is that they were able to get primary care docs and actually trainees, many from the U of H Med School, providing services there. And that was a wonderful thing, because up until then it'd be like we would order lab, we'd get the results. If it was abnormal, most of us didn't know what to do about it, and we refer to primary care, but a lot of our patients didn't have primary care docs, so now we got them in the clinic. My question is, do we have contraception available through those clinics? Because that's one of the other issues that, we have astonishing numbers of poor children in Texas. We have banned abortions. We have minimal access to successful contraception particularly for like unhoused women who often have little to no control over whether they're going to have sex with any particular guy, and that's one of those things that until you spend your career in the public sector, you don't know much about. So is that something that has happened or that might be able to happen in the future?
It's a great question, and I'll just put a little emphasis on it. Part of the reason we integrated physical health care into our behavioral health system is, if you're not familiar, patients who receive care in the public mental health system have a life expectancy that's 28 years less than people who don't have serious mental illness. And about 8 years of that is accounted for by suicide, but the rest of that is COPD and diabetes, and the same thing that kills everyone else, just much younger. And by the way, thank you for your service to the community on multiple levels. And so one of the things that has happened recently is two things that are big. One is we've had pharmacies, but they've always been internal, and we've converted those to retail pharmacies now. So our clients, if they have coverage, can get, and even if they don't, can have access to medications that are across the board, including contraception. We also have just submitted this month our application, fingers crossed, to be designated as an FQHC, and be able to provide
Good.
more comprehensive physical health care, as well as OB services, women and children's services. And so I'm optimistic about that. I think we have a compelling case. I don't know what HRSA will think and what the feds will think about it, but I do think it's important to be able to meet broader set of needs. We've done a great job long-term about meeting mental health needs in our community as a system, but people don't just show up with just mental health needs, to your point. They show up with lots of complexities and lots of other needs. So that's a couple of the steps, and I do appreciate the emphasis and the relationship with U of H and partnering with their physical health care providers in our system. It's made a really big difference. So.
I think we've got time for one more question right there.
So the Harris Center, Community Health Choice, Memorial Hermann are all members of the Health Information Exchange. And going to Ms. Wright's point about outcomes, what about leveraging a community asset like the HIE to determine, all right, where has this patient been seen or where has this member been seen? Whether it's a mental health, whether it's a hospital system, whether it's a community-based information to figure out what works and what doesn't work. That's specifically to you.
Thank goodness.
When you were saying it, I was actually thinking this sounds like Epic 3.0, and I just read that they are now valued at like $40.8 billion. So good for Epic.
You're their latest
First I want to say I
customer.
appreciate your question, and it's like the $1 million question, because there's so many systems out there, Find Help, Unite Us, Aunt Bertha. The problem is they don't close the loop. And so it's something that we've been, I think, collectively all talking about, but I don't think today we have a solution for. So, even with the best systems like Epic, there's so many variations of Epic. Memorial may be on one, Methodist may be on another, Harris Health may be on another one. So as much as we all want to raise our hand and say we're all, talking every day to each other, our reality is to what the senator said, it's sort of small steps. So, 10 years ago, we didn't have it. We weren't really talking. At least now we can go on, we can look, we can learn more, understand more, and know more. 10 years from now, maybe everyone will be on the same system and we'll have this system that you're talking about. But today, it is very fragmented because, again, you have a community-based system and then you have this health information exchange. And, I would say we're at Rice. This is an amazing institution. Sounds like a great business opportunity for someone to sort of help put together. How do we build sort of this health, community, and behavioral exchange that we can all look into and understand where our members go, and also referral patterns, right? So, but it does not exist today.
Yeah, we're making progress.
Yeah.
I mean, the HIE is not to the point where we can share information as effectively as you've described as we would like. Epic has a feature called Care Everywhere. Most of the major systems here in Houston now have Epic, and we do use it. Now, again, it's not where we want it to be. We have a way to go, but we're doing other things. We have a program, Methodist, Memorial Hermann, Harris Health collaborate for patients who make 10 or more visits to one or more of our emergency departments during the course of a year. And so we, as you can imagine, almost every one of those has at least some significant non-medical barrier to health. Many of them have a number of them. And so we've been collaborating together to share that information, identify those patients. When one of them comes, we share the information about the visit, and we have community health workers or navigators now who are assigned to those patients and try to help begin to address those non-medical barriers to health. So there are some good things happening. Again, the challenge for us is to figure out how to scale them and move beyond small groups of patients into something that's more significant and impacts a broader number of people.
Y'all put something together that kind of summarizes that population?
Yeah.
Oh, I'm curious to see that.
Yeah, we.
I mean, I can guess
we
what
need
some of the
MVP.
factors are.
share the list,
Yes.
and yeah, absolutely. And again, it's a little too early to tell if it's making a difference. We know we've reduced the numbers of visits to the ED, but the metric beyond that is how's their health on an individual basis. Are we making an impact? But there are some good efforts underway. I mean, to the point again, we just need to incentivize more efforts like this. And it's not so much about a lot of increased funding. We know that's not available. There's some available. That's good to hear. But instead, how do we take the funding that we have and create incentives for us to work differently to have greater impact?
And if I could quickly add, I appreciate your question because that's similar to one of the recommendations from our other work group focused on data, is recommending that HHSC do a landscape assessment of the tools and the opportunities and the challenges that exist currently, including the sharing of data around non-medical drivers of health. And so looking at that, finding opportunities, there's at least 3 directed payment programs right now that have some incentives to do more data sharing. And so I think that's an opportunity, as well as being cognizant when we think about the policy with things like House Bill 1575. We can't be too prescriptive on screening tools. It must be these particular questions because everyone is on a different system, and that we may not be able to adapt all of them as we need to, so that ability to be able to screen as we are able within our own organizations, and then share data in a common method to get it either into an HIE or between individual partners who are working together to meet those needs, I think is a really important strategy.
All right.
Thank you.
It's 6. Thank you so much. I could sit and listen to you talking to each other forever. Much appreciated.
Thank you for having the forum.
Thank you. I don't know if they've taken away our food and wine, but I'm going to check. Did they pack it up? Oh.